when I was a resident, we never MRI'd them. We just went in there, we kind of met with the patient, and we said, hey, listen, you've ruptured your Achilles tendon. When we get in there, these are the means of fixing it. And depending on how severe it is when we get in there, we'll dictate, what we need to do. I call that like a gift box, like practice, where it's like, hey, I'm going to open you up, and when I get in there, we'll see what was under hood number 3. That's just not my style.
Mhm.
And so I always MRI the patient. I like to show them, the MRI. And so the reason I MRI them is I like to go in and just execute the game plan. And so it's like, okay, this is what I need to do to get this Achilles back together, repair it, and get the patient a good outcome. And I need this tool, and this tool. And I have everything set and ready to roll. And so the shorter OR time, it's better care, and then ultimately you're enhancing the outcome. And so as long as the MRI is not going to significantly delay the surgery, then I definitely recommend getting it. And so there's lots of little recipes on how you fix it. And I use, the patient, what are their demands, what are their needs, and then how bad is the rupture, and the MRI helps guide that. And so it's kind of like that puzzle piece that you have to use to get that perfect outcome.